I'm Claudine Wong with KTVU in the San Francisco Bay Area, and I'm joined now by Dr. Christian Ramers, who's an infectious disease specialist with the Family Health Centers of San Diego. Thanks so much for joining us.
Thanks for having me.
So let's just start out with the state of California right now. It is in all the headlines for the fact that our numbers have surged. There's some talk about them flattening in terms of what we're looking at right now. I can just for, the basic numbers, share these numbers from the State Department of Health, where we see things going up and tests reported and cases. From where you sit, how are you feeling about where California is right now?
Well, California was a great example of how to do things right in the beginning. And there have been articles penned that even called it the California miracle of how we flattened the curve so early on. And I think it's pretty obvious to those of us involved in this that as we opened up, we expected numbers to surge a little bit. I think we probably opened up a little bit too quickly. It's hard for people to admit that, especially the decision makers. But I think rather than be just on one camp that says we should shut down everything and stay shut down, or another camp that says we should open up everything, we need to hit this really fine balance of allowing our economy to keep working and yet doing it safely. And we probably just missed a little bit too far on the opening up side of things. There have been a lot of people discussing this as sort of the hammer and the dance. I don't know if you've heard that term, where the hammer is shut down completely, and then the dance is trying to delicately dance back in close to what our sort of new normal life looks like, or some people call it a dimmer switch. The trouble with this virus is that the changes that we make today don't really show up in the numbers for about 2 to 3 weeks. And so, we probably went open a little bit too quickly, and that's why the cases have surged so much. And now it's time to sort of dial it back as we have done.
So dialing it back as we've done, is there another area that we're missing? I mean, and really, when you talk about those two approaches, you have State Senator Steve Glazer, who's in Orinda in the Bay Area here, saying, let's just shut it down for 3 weeks and restart, have that miracle again, and then reopen the way that we maybe should have in the phases that we should have. Obviously, people don't want to be shut down again, but he was saying, look, it's just too out of control, and if we just do that, that would change it. I think, for those of us not in the medical community, it's hard to know what is the right way to do that, and how you decide whether it's the dimmer or the switch.
Yeah, well, a lot of the discussion has been around, treating counties differently. And, we are a huge state of 40 million people, and very rural counties in Northern California with very few cases, I think really should appropriately have a different strategy than big places like Los Angeles, San Francisco, San Diego, Orange County. So we really need to pay attention to our data. I really like what I've seen in San Diego in terms of the county HHS, the Health and Human Services Agency, really creating triggers and tracking metrics of new cases, of hospital capacity, of the ability of the public health infrastructure to even track cases, and then using all that data to turn that dimmer switch appropriately. We're now in such a surge that we're sort of on the watch list in San Diego, and so we need to shut things down. And what they've done is really follow the data. So in San Diego, they really decided to close in-person dining in restaurants. They decided to close barbershops and that type of thing. And that was really based on the outbreak data that we were seeing in our local area.
But the downside of just shutting down completely is it purely economic? Is it not going to be effective? Is it just trying to create a balance? I mean, from a pure science point of view, you can see why some people would say, just do it, it'll be faster, or is it, taking everything else into account?
No, don't get me wrong. I mean, if you really wanted to beat this virus, all we would have to do is not leave our homes for 14 days. Period. If we were just to freeze everything, it would go away, really. But we can't really quite do that. And even me as an infectious disease person who's on sort of the side of the argument that would want to shut down even more, we have to be honest about what is acceptable to our society. And people have shown, in their activity, in their cell phone data, in the, Open Table has been tracking restaurants and all these types of things. Even when we had very strict shelter-in-place orders, we didn't fully lock down the way a lot of other societies did. So, Tony Fauci has talked about, we didn't really fully shut down our activities. We sort of half shut down.
And the halfway doesn't work, right? The halfway isn't, it just strings it out even longer as well.
It doesn't, and just to be really frank, Americans don't like to be told what to do. Things that work in other societies where there's just a much more deep trust in the government. I was in Taiwan last year, and people really trust their public health authorities, and they, I think one of the prime minister or somebody is an actual epidemiologist. They have a lot of faith in government. They do what they're asked to do, and we have a very different culture, a very different society. Some of the tracking strategies that have been used in places like Korea would be illegal in the United States. And we just have to face that. Tracking your purchases and your transactions and your location on your cell phone, it's considered an invasion of privacy. So it just doesn't quite work for the US. And that's why I think the extreme version of shutting down, while theoretically would be the best way to do it, it just doesn't quite work in America.
And let's talk about going back to California too. I mean, when you talk about the different counties and the different states and the different regions that are handling things the way they're handling, just even in California, I mean, give us some Southern California perspective, right? Because we're all on the watch list up here in the Bay Area, but our numbers, it's all relative, right, to our percentage of increases and how, in cases. And certainly we're seeing plenty of surge up here. But when we look at a map and you look at what's happening in Southern California, there are some people that, I hear from Northern California going, what is going on down there? Is it just the beaches? Is it, is it that people really just don't want to wear masks? Like, what is causing the Northern California versus Southern California, change in how it's being handled? Obviously, the Bay Area was pretty conservative and shutting down very quickly in general.
Yeah. Yeah, I think each county is unique. It's part of the beauty of our state is we have such diversity in our counties. And I think it's maybe a different aspect of this pandemic in each case. So with Los Angeles, I would say that there's just such population density. It's just very hard to socially distance when you have that many people in a small area. With Orange County, I think we've seen the news stories that culturally, masking has really not been, there's not been great uptake of that for whatever reason. In places like Imperial County that had really huge surges, there's a lot of influence of agricultural workers and the influence of being a cross-border town from Mexico. Many Americans that live in Mexico were the ones that first crossed the border into El Centro and really overwhelmed the hospital systems there. And then as we're seeing now, if you look at heat maps in California, the Central Valley and Stanislaus and Fresno and Kern counties are really seeing large surges, as well as Sacramento and San Joaquin. And I think that has to do with agricultural workers' conditions as well. It's a very complicated mix, but all of those things really bear on what our case rates are. Mask wearing, density of essential workers, population density, and then the individual county's response. And I have seen some data to suggest that in the Bay Area, generally people were quite compliant with masks. Again, that sort of trust in government and a data-based approach. And other places, that's just not the case.
So, in your work with the Family Health Centers of San Diego, you have a unique position too in what you're seeing, and we were talking about before we started this interview on just the community reaction and the ability to serve the community, and specifically the community you serve, and the numbers and the disproportionate numbers that you're seeing. Give us a little more insight on that, simply because you are also close to the border.
Yeah, I think this can be summed up in our testing numbers. It really doesn't make sense to just look at testing in a giant area like the state of California. It really has to be much more granular. And even within San Diego, our county testing numbers, we wanted to get to a goal of about 5,000 or 6,000 tests per day, which we were able to do. Public-private partnership of the county, as well as some of our academic and university places and our community clinics. All together, we reached about 7,000 tests per day, which is great. We've got a nice blanket of the community. But an example of how granular you need to be is that the county positive test rate is about 5% on average, which is pretty good. The WHO says that's about a good enough test to sort of do contact tracing and handle things. But just looking at our Family Health Centers data, we have been hitting 10% positivity rate from March, April, May, and we're up to now 13 to 15% positivity rate.
Wow, that's a very big difference.
Really different story. Just in different neighborhoods, we are serving a lot of low-income individuals, working class people, and we're also doing sort of more easily accessible community-based testing. We are really literally out in the neighborhoods with walk-up testing. And then you see rates of about 15%. And that, to me, tells us that we are not doing enough testing in the right areas. And this is a very difficult problem that the state has had to face. Like, first get the numbers up to what they need to be. But if you do that just to get up to 6,000 or 7,000, and say that you're done, that's not enough. You have to actually start targeting things. And I've heard the governor say this in some of his talks, that we need to start being laser focused on the data and really making testing available in the communities that are most affected.
Yeah, let's talk about testing, because I know up here people are talking about, waiting 14, 15 days to get their test results back, which is obviously not effective when you're talking about contact tracing and everything that you do once you find someone that is positive with COVID-19. Are you seeing the same thing? Is that a statewide problem? Is it a Bay Area problem? And is it a problem that you, as an infectious disease expert, how do we fix anything if we can't fix that?
Those numbers are really disappointing to hear, Claudine. I mean, it doesn't make any sense to do a test and wait 14 days. You've had the entire incubation period of the virus, where someone's been able to go around and spread it to other people. The important part is, what advice do you give somebody while they're waiting for the results of the test? And really, the advice should be that you quarantine until you know, because you could be spending those 14 days spreading to other people. It's really hard to talk about this in just one way, because we are such a patchwork of different systems. Our healthcare system is so fragmented that I think a large contributor are the big commercial labs that have had huge backups from the numbers that they're trying to reach. And yet in smaller testing, defining smaller universes, you can get relatively good turnaround. So in our system, we've really held a goal of 48 hours to turnaround. And we've actually limited the number of tests we're doing if we're not able to reach that goal. Because the test, again, it just becomes completely useless if you don't get results for 14 days.
Yeah, it is a tough thing. Okay, let's really switch gears really quickly to this. Moderna's been in the news with this vaccine trial going to 30,000. From where you sit in terms of, I feel like at the beginning, everyone was very like, when's it coming? When's it coming? When's it coming? Now, proceed with caution. Do you get a lot of those questions, and what do you tell people that ask, are we closer to an end if these vaccine trials that all hit new phases all through the fall? It seems like there's so many of them. Are you optimistic? Are you cautiously optimistic? Are you not even thinking about that yet? And are you getting more faith in the treatments and how you actually treat COVID before we try to prevent it?
Yeah, as an infectious disease specialist who has personally seen people die of vaccine preventable diseases, I'm very much on the side of vaccines. That is really our one way out of this. We have been able to dramatically decrease rates of polio and tetanus and pertussis and cervical cancer and hepatitis B infection, hepatitis A. The list is huge of how effective vaccines are, because it should be almost a one-time intervention where you get people protected. You hopefully will reach herd immunity, which is about 70%, we think, in this disease. And the mental exercise of thinking what it would take for us to reach herd immunity by natural infection, which was sort of an idea thrown out by the government of Sweden and other places, there would be so much death to reach 70% herd immunity from natural infection that vaccines look like they're really the one way out. I think cautiously optimistic is a nice way to put it. There's been an immense and collaborative effort from pharmaceutical industry plus government plus researchers. Almost anybody working on any kind of virology, including HIV researchers, have really pivoted. So we have the full force and power of academia looking for solutions here. And so far, so good. There hasn't really been any major problem so far going from phase 1 to phase 2 studies. Of course, we need to wait for the data that's really just starting now with the phase 3 trials of about 30,000 people per vaccine.
But should we be worried about all those stories that come out that say, well, the antibodies fade after X amount of weeks, and that it may not get us to where we want to be, and it may, and people are getting COVID twice possibly, and all the discussions that come up as we watch a vaccine progress, as maybe no other vaccine has been watched so closely, and potential candidates, are those things that concern you?
Yeah, I think these are all normal concerns to walk into this situation with. We should have our eyes open, and we never should be too confident. This is actually how science works, is you have to prove yourself right, and you have to pay attention to your mistakes, and you have to be humble. But I think, the reports of fading antibody levels have been more prominent in those with very mild infections. The reports of reinfections, I think, have largely been sort of diagnostic mistakes. So South Korea had a great in-depth study of about 285 people that looked like they were reinfected, and none of them actually were. And none of them had any culturable virus. This was just a positive test that turned negative temporarily and went positive again. So I don't think reinfections are going to be that big of an issue. And then there's also, the immune system is incredibly complicated, and antibody tests are just one little arm of the immune system. And it may be that T cell immunity, which we don't have as good of easy, convenient tests to measure, may be even more important. So, we are all thinking that this is probably going to behave the way other coronaviruses have behaved in the past. And it looks like, almost everybody that gets the infection will develop neutralizing antibodies. And almost everybody will have those antibodies for months to maybe a year, year and a half, 2 years. And that's about what we've seen with the vaccines. Of course, we need to do the tests and the trials to find out for sure. But so far, things have looked really quite good, both with antibody responses and with T cell immunity as well.
I mean, obviously, there are a lot of people who are fearful. Would you sign up right away to get, when it passes, to go ahead and get your shot, and your family to get their shot? And I think people are, the fast track scares people.
Well, this is a key and very crucial issue going forward that we're involved in. Communities of color in particular are very suspicious of biomedical research. And I think with good reason, because of really unethical things that have happened in the past. And yet all of us involved in this effort feel like we need to do vaccine trials that are representative of the communities that are most affected. So it's a duality that I struggle with really all the time, which is that in San Diego, our Latino communities are making up way disproportionate numbers of cases. So about 60 to 70% of our COVID cases in San Diego are amongst Latinos, the Latinx community, and the Latinx community makes up about 30% of our population. So that is the definition of a health disparity, where twice as many people are getting COVID as they are represented in the population. So we know that we need to do a vaccine trial that involves the most affected communities, and yet we're coming from a baseline of suspicion, which is warranted, and concern about safety. And then also the fact that this is research, this is not really availability of the vaccine yet. So we need to explain, what does a placebo-controlled trial actually look like? So I don't think I have a full answer of how to do this correctly. I think that the best stance for us to take is to partner with the community and address concerns at the outset. One of the most common questions that we get from communities is, okay, we understand you want to use our communities for research. Will we be able to benefit from this when it gets approved? And unfortunately, the way research is set up, that's sort of a different arm of the monster that decides that. That's Medicare, Medicaid. But we've asked the investigators of these vaccine trials to be very, very strong in their recommendations to make this vaccine available to everyone. And I don't want to minimize the safety concerns. There certainly are safety concerns with all vaccines. But by and large, the FDA process that approves vaccines has pledged just yesterday that they are not going to cut corners for political reasons. They're going to use their same standards for safety. And we're looking, again, we're going in this with our eyes wide open. We're looking for things that we think will be important safety signals. There's a phenomenon called enhancement, where in certain diseases, a vaccine might actually make the disease worse. Of course, we're looking in detail at that, and the preliminary data looks like it's very good for these vaccines so far. We're looking for rare vaccine side effects that have to do with the immune system, such as Guillain-Barré. And I've seen some of the protocols, and they are in very detailed ways looking for all of these adverse effects.
Yep. I do have to ask you, because we've had so much, and you talked about trust, and you talked about the situation of people trying, in the messaging, without being, without going into what the claims were. There have been in recent times these YouTube videos, or these press conferences, or these, things that talk about in a very smaller portion of varying medical opinions from doctors, or varying opinions from doctors about the medicine. How do you think that we approach the medicine so that, and you talk about, so that people feel like they are getting the best, so that the safety protocols that are recommended by top experts are trusted?
That's a really good question. This is the first pandemic, I think, if I'm thinking back 2009, we had H1N1, but this is really the first pandemic in the era of social media where anybody with an internet connection can just say, hey, I'm an expert and I'm going to say what I want to say to the world. And then things, quote unquote, go viral, and it's hard to know who to trust. But the way science happens hasn't changed. Science happens by peer review that is very careful and very cautious. And if you cannot provide evidence to prove what it is that you're saying, it does not make it into mainstream science. That's why we have journals. That's why we have peer review. That's why we have people able to openly and honestly critique each other's data. That hasn't changed. What has changed is the onslaught of people just being able to go out and say what they want to say without being criticized and without defending their claims with evidence. So I think as a journalist, this is part of where we need your help. Is that there are tried and true ways to prove things and to provide evidence that backs up your claims and your statements. And I think we sort of need to fight against the myths out there that are people just sort of standing up and saying, "I think I know what I'm talking about," without relying on evidence. And when I say evidence, that means a very, very specific thing. I'd use hydroxychloroquine as a good example here. So it's not easy to prove or disprove whether something works. Not easy at all. And if you just do an unblinded single-arm trial, it can be very confusing. This is what happened in the very beginning with hydroxychloroquine and azithromycin from the small French study. Sure, it looked like it was great, but how do you prove it? You certainly don't prove it with a single-arm, non-randomized trial. You do it with a large, double-blinded, placebo-controlled trial. And you might hear those words all the time, but if they don't mean anything to you, you sort of take one thing as equal as the other. They are completely not equal. And this is what scientists and people that are serious about this are doing to really arrive at the right answers. And we have, thankfully, the NIH and the Infectious Disease Society of America that are looking at all the evidence and grading them with a very rigorous evidence-based strategy. So, my answer to that is that you should trust people that can show you when they're wrong, that are humble enough to say when something doesn't work, and that can really be open and honest about the data and the evidence supporting it.
And puts their thoughts to the community, the scientific community, for everyone else to weigh in. Not one doctor, but multiple experts taking a look at the same concept, the same theory, the peer review.
Right. The whole concept of peer review is that I'm not going to believe a single word that you say unless you prove it, and you prove all of the experts around the room that are able to pick apart and critique what you have to say. And if you can't defend it, then it doesn't stand in science.
It doesn't stand it. Absolutely. Okay, before I let you go, I do want to talk really quickly about masks, because we talked about, you've touched on that and the effectiveness of them. And I know that as people they're kind of on I don't want to wear them because of XYZ, or I'm wearing them, but the people who are wearing them also want to know how effective they are. And there are so many different versions. Are you of the mind that if you just wear anything, then it's going to be helpful, or should we be obsessing over the 2-layer, 3-layer, the carbon filter, the gator, there's so many different versions of what people are wearing. And do you, I went on a walk on a trail, and someone was like, you've got to be 6 feet away. Then someone else isn't wearing a mask, then someone else isn't. And you could really, if you are trying to be a good citizen within this space and stop this surge, kind of lose your mind on what what is the responsible thing to do here.
Yeah, I think you hit the nail on the head. We have lost our mind. It's important to remember where this all came from. And, a lot of people will point fingers and say, well, the Surgeon General in the beginning was saying, don't wear masks, they're not effective. This is what I mean by being able to be humble and change your advice when the evidence changes. Even the WHO, which has been quite late to the game, I would say, in recommending masks, did so because of, at the time when we were talking about, March and April, the evidence wasn't really there in support of masks. And there were legitimate concerns about our medical providers not having adequate supply. So we said only masks for people in hospitals that are healthcare workers, and everybody else is fine. That evidence has evolved very rapidly, and it's like masks just keep getting better. It's like every week there's another paper that comes out from a different angle showing the effectiveness of them. They protect other people around you from your own secretions. There's more evidence showing that it probably protects you no matter what mask you're wearing, with different levels of effectiveness, starting with just cloth masks, going to layered masks, going to surgical masks, going to N95s. And so they're each a little bit better, but everything's better than nothing. And then we've seen on a population level that countries where masking is culturally acceptable and common have a lot less transmission. Hospitals and health systems that early on implemented a universal masking policy, that means whether you have symptoms or not, see their curves flatten a lot quicker. So the evidence is really, really overwhelming. And I understand there's sort of this freedom, I don't want the government telling me what to do type of thing. but it really isn't that much different than drunk driving or wearing seatbelts or having to have insurance in your car. Minor inconveniences that you have to put up with because we have a social contract within society. And this is really one of them, that wearing a mask, we all want to go back to sort of a quote unquote new normal. We all want to get back our businesses open again. And masks are really the best tool to do that because they are the most effective prevention intervention that we have right now.
Okay, so as a quick, unless you have something very specific that your doctor approves, do masks harm you in any way?
No. So again, back to the sort of social media, I can say whatever I want to say. There's been a lot of videos, and I've analyzed these in detail, that people that bring like a partial pressure of oxygen meter from their workplace, and they put it right in front of their mouth, and they say, see, when I blow out, the oxygen level goes down to a quote unquote dangerous level that OSHA doesn't want me to breathe. Well, that's just a misunderstanding of basic physiology. The oxygen content of the air you breathe in is higher concentration than the oxygen content you breathe out. And if you watch those videos, the sensor goes down to like 17%, which is what the oxygen content is of exhaled air. And within seconds, it goes back up to 19% because of something called diffusion. So, but people misunderstand those videos, and then they get tweeted everywhere and everything. So they are not doing any harm. Look, I wear a mask for 12 hours straight at work, and I'm fine.
Okay, and then wear a mask no matter what. And should you be running with a mask? And I actually think what you said was interesting. They protect you and the other person, because for a while also the theory was that you're doing it for the other person, but you are also doing it for yourself.
Yeah, there's some recent data about sort of a dose effect. So it looks like if you get a huge inoculum of, you're not wearing a mask, someone else isn't wearing a mask, and they cough right in your face, that's a huge number of virus particles that's going to get in. And that compared to a smaller number, which may get around the corner of a mask or something, that you get a whole lot less sick. So the dose response is really important. So we do think that it protects the person. Just a note on should you wear it all the time. I actually don't wear a mask when I'm out running, okay, or cycling, because it's outside. There's so much air to diffuse, and I can run and keep my 6 feet of distance, if I need to. So there are times when you
So if
don't
someone
really
run
have.
past you, don't freak out. If you're running past me and I'm wearing my mask and walking, and people shouldn't stress out about that.
You shouldn't stress out as long as you can run, 6 feet away from somebody. It's good to have a mask with you in case you get too close or it's too crowded, just to pop it over your mouth in that situation.
Okay. All good information, very practical information as we try to navigate what has been nothing short of just a crazy time for everyone. Dr. Christian Raymer is an infectious disease specialist with the Family Health Centers of San Diego. Thanks so much for your time.
Thank you. Stay safe.